Good morning. Today we will discuss an important next chapter of your series as neuroophthalmic disorders. Neuroophthalmology is a branch which is a mixture of neurology and ophthalmology, and it concerns mainly the visual problems that are related to the nervous system. It is not that only the eye is involved, it's that the nervous system is involved, that's why the eye is involved. And vice versa, but that because the eye is a offshoot of a nervous system, and hence nervous system and the eyes can't be separated because the second nerve is the offshoot of the central nervous system. And some commonly seen diseases that the neuroophthalmologist may see includes optic neuritis, optic neuropathy, papilloedema, and optic atrophy. All are the diseases of the optic nerve that the neuroophthalmologist sees. See, in glaucoma we see the visual fields. We do the perimetry, the static perimetry. This you see on the upper left hand side of your screen. This is the examiner is doing the concentration field test of the patient. In this test, what we do is we have to tell the patient to close one of his eyes. If the patient is closing his left eye, you have to close your right eye. Okay, if the patient is closing his left eye, you have to close your right eye so that his right eye and your left eye are parallel to are just opposite to each other. And after that, what you have to do after that, you bring your finger how much later you can keep your finger, and tell the patient to tell you when the finger first appears as you bring it towards the center. Mind it, the eyes of both you and the patient have to be in the primary position. Similarly, you have to repeat for the other eye. Like if we have to do it for the left eye of the patient, we have to close our left eye so that our right eye is looking into the left eye of the patient, and we can do the concentration test. And in the concentration, we have to bring our finger from all the directions to the primary position and ascertain whether when does the patient first respond to the stimulus. Okay, so this is the visual field of the patient of the right eye. What is a visual pathway? What comprises the visual pathway? The first thing in the visual pathway, when the ganglion cells give the fibers and they combine to form the optic nerve. The optic nerve is formed by the axons arising from the retinal ganglion cell layer. Okay, then it passes out of the eye through the lamina cribrosa in the posterior surface of the eye which is a part of the sclera. Through the lamina cribrosa, it passes out of the eyeball. It is then surrounded by the dura mater, arachnoid mater, and pia mater, and this is continuous with that of the surrounding brain. Now the optic nerve extends from the posterior pole of the eyeball to cross at the optic chiasma in the middle cranial fossa after going out of the intraorbital canal from the orbital apex. The fibers travel after the chiasma crossing in the chiasma. After the medial fibers cross in the chiasma, they travel as the optic tract, and most of them go to the lateral geniculate body in the thalamus, and very few of them go to the midbrain to the third nerve nucleus. Where it goes to the midbrain to the tectum. These fibers leave the lateral geniculate body, forming the optic radiations up to the visual cortex. Okay, after the lateral geniculate body, they arise from there and then reach and then as optic radiation, they reach the primary visual cortex. And the primary visual cortex is responsible for processing the visual information, and this is located in the occipital lobe. So, the visual pathway, these retinal ganglion cell fibers arise and the fibers go behind and cross at the optic chiasma. After the optic chiasma, the optic tract goes to the lateral geniculate body and few fibers reach the midbrain down. After that, after the lateral geniculate body, the fibers transfers in the form of optic radiations to reach the visual cortex, primary visual cortex in the occipital lobe. So the disturbances in the visual pathway lead to many scotomas and hemianopias. For example, when the nasal fibers, for example, in the visual pathway, if the nasal retinal fibers are involved, the right visual field will go of this eye. If the temporal fibers of the left eye and the nasal fibers of the right eye, both the patient will not see the right visual field. Similarly, in the left visual field is not seen when the fibers concerning the nasal fibers of the left eye and the temporal fibers of the right eye are involved. So, if the lesion is in the optic nerve, okay, when the lesion involves the optic nerve, for example, of the right eye, so the all of the visual fibers which are going to the brain are disrupted, so the total vision loss will be there in the right eye. If the lesion is involved the middle of the chiasma, there will be a bitemporal hemianopia, which will be seen particularly in craniopharyngioma or pinealoma. If the lesion involves the optic tract or right optic tract, the lesion will be in the left visual field and the hemianopia will be non-congruous. If the lesion involves the occipital visual cortex, then there will be congruous hemianopia. Okay, congruous hemianopia. The optic nerve is about 50 centimeter in length and it comprises of an intraocular portion, the orbital portion, the intracanalular portion, that is which runs into the intraorbital canal, and the intracranial portion. The intraocular portion of the optic nerve, it is visible when we use a direct ophthalmoscope or an indirect ophthalmoscope, and it is visible as an optic disc. The central retinal vessels, okay, these are the central retinal vessels, enter and leave the eye at the optic disc. There is a complete absence of any of the focal receptors, and thus this is known as a blind spot in the visual field. Normally it is slightly vertically oval with an this is a slightly vertical oval with an average diameter of with an average area of dimensions of 1.76 millimeter horizontally and 1.2 mm vertically. Okay, and normal color of the optic disc is yellowish orange. It has a sharply defined margin and the nasal side is slightly less distinct due to the greater density of the fibers here, and it is not due to any disc edema. It is due to more fibers, that is greater density of the fibers there, that is the nasal margin is not so sharply visible. There is a central depression in the optic disc called the optic cup, and the optic cup comprises of the lamina cerebrosa. The optic cup is the pale center of the disc and it is devoid of any neuroretinal tissue. It is important to document the size of the cup, and this is specified as a horizontal and the vertical cup to disc ratio, CD ratio. Okay, the normal cup to disc ratio, the CD ratio is, the cup to the disc ratio is 0.3:1. The cup and the cup is the second turn of the vessel. The cup is the second turn of the vessel and not this pallor area. Okay, increased cup to disc ratio indicates a decrease in the quantity of the healthy neuroretinal tissue and hence indicates the glucomatous change. What is RAPD? Pupils are equal in size and they should respond equally when a light is directed onto the pupil of either eye. Okay, if the pupils are equal and of normal size but the pupil's response to light directed on the affected size is reduced, it is known as relative apering pupillary defect. Apering means to take the signal in. Okay, this sign is observed by using the swinging flashlight reflex. Okay, the torch is shown to the first one eye, then it is swung to the other eye, then it is again returned. Okay, like a flash. Okay, it is seen as both the pupil's dilation when the light is swung from the normal to the abnormal eye, and the affected side will constrict less, therefore appearing to dilate. Where RAPD is seen, it is seen in optic nerve lesions or very severe retinal diseases, and lesions of the optic nerve on one side block the afferent limb of the pupillary light reflex, and hence the signal slows down to the third nucleus, and hence the pupil appears to dilate rather than constrict when the light falls on it.